So good evening everyone. Thank you Dr. Gang sir for a very detailed management of the hypertension from the basics to advanced molecule. So my task is today about the secondary hypertension, how to suspect, how to approach the patient. So hypertension is the biggest contributor of global burden. 30% of patients or 30% population of India, they suffer from hypertension and is the most common chronic medical condition. And if you don't find the cause, then it can cause like 90% of patients, they suffer from idiopathic hypertension. And only 5 to 10% patients from secondary have cause of secondary hypertension. And we must have to try to find out the cause of secondary hypertension. If you don't find or if you don't treat in certain population, which can lead to the significant cardiovascular and renal complication. So certain group of patients, we always try to find out what are the reasons of the secondary hypertension. And many times is overlooked and we do many tests, we don't find any reason and we have to explain the patients. Commonest thing is a cost in our society. So to explain the patient that you may have to spend and the result comes normal, but still we have to investigate further in certain group of patients. So if you see here, secondary hypertension is only 5% of patient. So that is very, very not so common, but still these are the different reasons what we go from initially. So there are renal causes, endocrinal causes, vascular causes, iatrogenic, which are reversible. Some causes are reversible, some causes are irreversible. And the irreversible causes are, if you think, mainly the first we discuss reversible cause is renal artery stenosis, which is one common we should not miss in our practice. Second is a small pyelonephrotic kidney, large hydronephrotic kidney, iridescent tumor. In endocrine causes, we have Conn's, pheochromocytoma, Cushing syndrome, thyroid disorders. Vascular, we have coarctation, again, which is common in the younger age. And we should not miss because of which is very long-term significant mortality and morbidity. Vasculitis, again, which is very rare, Takayusus, polyarteritis, scleroderma. And iatrogenic causes, drugs. So commonest thing we should not forget in our history taking drugs, whether which patient are any iatrogenic drugs related hypertension or not. Commonest drugs which can cause hypertension are glucocorticoid, NSAID, contraceptive pills, decongestant, sometimes alcohol as well. Reversible cause is a chronic renal failure. As Dr. Gang sir said that majority of patients with a renal failure, they suffer from hypertension. And polycystic kidney disease that can be reversible and patient has to take lifetime antihypertensive medication. So who should we screen for? So we discussed the already common causes of secondary hypertension, but now which patient we have to investigate further? Any patient who has diagnosed hypertension in the younger age, less than 30 years of old, who has family history, does not have family history of essential hypertension, who are obese, they should consider for the screening for the secondary hypertension. Resistant hypertension, so patients who are on 3 or more antihypertensive medicine, which is either not controlled or 4 medication which is controlled, then we have to find out the reason. Sudden increase in the blood pressure rise, which again we have to doubt about secondary causes. Another most important thing is the ambulatory blood pressure monitoring in a non-dipping or reverse dipping. So usually the hypertensive patient at night time blood pressure dips down, but when you see in ambulatory blood pressure recording, there is reverse dipping, then you would always suspect something wrong with the RAS system or something wrong with the obstructive sleep apnea, and then we will consider for that. Patient with target organ damage also is to screen for the secondary hypertension. So this slide shows about the age, what age, which cause are common in secondary hypertension. If you see in this slide, the younger age. So patient who are younger, that you always think for coarctation of aorta, which patient less than 20 years of age. Then as the age advances, the renovascular atherosclerotic patient, which is more common after the 50 years of age, while the similarly renal vascular hypertension, fibrovascular dysplasia, which is common in the younger patient. So we have to very particular about the age-wise, while the other secondary cause like pheochromocytoma or paraganglioma or pyramidalis system, which is common in the middle-aged patient. So age is one of the things to decide about whether patient required to investigate further for secondary hypertension or not. What workup you to do it? So basically, any secondary hypertension, we have to confirm first whether it is pseudo hypertension, whether it is stress hypertension, white coat hypertension, and multiple times we ask for the sometimes home blood pressure monitoring, which is more popular in the Western world nowadays. And multiple readings, when we confirm this patient has hypertension, then we have to ask detailed history. Physical examination should be performed. We'll discuss in the next few slides. And always ask for the secondary cardiovascular risk factors, including diabetes, hyperlipidemia, family history, and smoking. So, but now because of we are overloaded the clinical burden, so we always go very fast. So we go for investigations rather than detail about taking history and examination. So, but this is very important in all the patient. So these are the flow chart how you investigate further. So if you see here, the 24-hour blood pressure remains a very important tools to decide further, and then the confirmatory, we have to always ask about the adherence to therapy. Many times patient comes with us and they don't take any medication regularly, and there was one study in UK, they have confirmed that patient with resistant hypertension, they don't take the medication regularly. So adherence is very important to assess before we investigate for secondary cause. So these are the medication which always ask in history about the NSAIDs. Many times OA arthritis patient who comes to us with the itracoxib long-term NSAIDs group, and that we have to always find out. The oral contraceptive also again in the female patient, we have to ask about this history. In renal patient post transplant, the cyclosporine tacrolimus, which is again medicine can cause hypertension. Of course, there are the other medicine like glucocorticoid is a topical or systemic use, antidepressant, amphetamines. That the medication list we have to consider in our history taking. So the obstructive sleep apnea, many times we just ignore this, and especially when the BMI is high, the history we have to ask about the snoring, daytime sleepiness. We can see the examination finding about the obesity, and we do sleep apnea study to confirm. So if you treat the OSA, then patient hypertension remains under control, and the requirement of medication also reduced. So we should not forget OSA as a in our first list to decide whether this patient should be treated with the sleep apnea CPAP machine or just continue medication. This ambulatory blood pressure monitoring, if you see in this is OSA, there is a reverse dip. So at night time, there are the, ideally there should be dipping of the blood pressure. But in OSA, there is a reversal of nocturnal dipping. So instead of decreasing blood pressure, it goes high. And you can see in this graph, there's night time, there's increasing heart rate, increasing blood pressure, and that again suggests you of increasing sympathetic activity at night, and that leads to the diagnosis of OSA in the ambulatory blood pressure monitoring. Coming to renal parenchymal disease. So renal parenchymal disease is the most common cause of secondary hypertension and responsible for 2 to 5% case of all the hypertensive patient overall. So usually 80% of patients who suffer from CKD, they suffer from high blood pressure. And already sir has discussed about how to manage. Glomerular hypertension are more severe than interstitial disease of the kidney. So these are the renal cause of the hypertension, which includes glomerulonephritis, pyelonephritis, interstitial nephritis, polycystic kidney disease, which is again irreversible causes and require lifetime treatment for blood pressure. Which is a renal artery stenosis, which is the most common cause we come across in the renal cause of the secondary hypertension. And again, I mentioned earlier, if the young patient diagnosed renal artery stenosis, we always think for fibromuscular dysplasia. And while the elderly patient who has other risk factors like smoking, coronary artery disease, stroke, they are more suffering from atherosclerotic renal artery stenosis. Why it is important to find out? Because of the management is different. And there is a classical, if you see in the second slide, there is a beading appearance. So beading appearance in the mid to distal portion, which is more common in the fibromuscular dysplasia, while the proximal ostial renal stenosis, which is common in the atherosclerotic disease. The other cause of the renal artery stenosis is the aortic renal dissection, sometimes V malformation, post-radiation of renal artery, which can cause renal artery stenosis. The pathophysiology is very important to know here. So pathophysiology is different in the unilateral and bilateral renal artery. I am not going to go details about that, but the unilateral renal artery stenosis, they have increased activation of RAS system. However, the second kidney, which is normal, that suppress the RAS, and that neutralize the effect of RAS system. So this patient should receive the ACE or ARB. So commonly we think renal artery stenosis, avoid the ACE ARB, but that is not the true. Neutral renal artery stenosis, you have to give the ACE or ARB, which is a very high evidence we have. Bilateral renal artery stenosis, both the kidneys are affected. with the decreased renal perfusion, which can cause again activation of renal arteries, renal angiotensin system, and impaired sodium excretion, volume expansion, affect the RAS system inversely. So this is important to know pathophysiology. So this difference of the renal artery stenosis is already mentioned. Atherosclerotic is more common in the elderly, more common in the male, while the dysplasia FMD is more common in the female and younger age, and is more in distal two-thirds of the renal artery, which is, we can see in this slide, how the atherosclerosis is on the left side and the right side sort of FMD dysplasia. So the treatment of the FMD is highly successful with the angioplasty. So this patient does not require renal artery stenting. This patient just requires simple plain balloon angioplasty of renal artery, and patient will get better with the 100%, almost 80 to 100% success rate. And restenosis rate is less, around 5 to 10%. And you can cure the hypertension 60% of patient. On the other side, atherosclerotic renal artery stenosis are more difficult to treat, and there are more chances of restenosis. So if you see, there is 1 year restenosis chances are almost 25%. Because barometer stent we use. That's why routinely we don't advise to treat all the renal artery stenosis, because nowadays cardiologists, wherever they see blockage, they put the stent, but that is not true in the renal artery, atherosclerotic renal artery stenosis. Here there is certain particular indication when only the stent is required, which could be either patient has a flash pulmonedema, recurrent pulmonedema which is unexplained reason, patient has shrunken kidney, we have isotope scan result that is one kidney is getting less blood supply, and then we treat the patient with stenting, but again response rate is only 30%. So it doesn't mean if you put the stent that means patient is going to recover the blood pressure. That is not right. So we have to explain the patient before putting stent that only 30% chance you may get rid of the blood pressure medicine in atherosclerotic renal artery. The diagnosis, the sensitivity always there. We commonly go for renal artery Doppler study, but again, if you see renal artery Doppler study has a there are limitation, is operator dependent. When obese patient, you may not get correct results. The sensitivity, if you pick up, then is good, but there are many times we missed on the renal Doppler. Then we go for the either MRA or CT angiography, which again has a contrast. Gold standard for the renal artery stenosis diagnosis is a conventional angiography, which is invasive but with nephrotoxic. The bruit, clinical examination we always tell in medical residency, you always listen for bruit. If you find the bruit, then your having chances of renal artery stenosis are very high. But if you don't find, that doesn't mean the patient has no renal artery stenosis. So again, clinical examination has certain limitation. So these are the guidelines, the European guidelines published in 2018, and here they said the CT scan or MRA are and the ultrasound is of 1B class of indication, and the plasma renin measurement, again that comes class 3. So you don't measure the plasma renin in each and every patient. The olden days they used to measure ACE provocation test, but now we don't do that. So treatment strategy, ACE or ARB, as I told before, that these are the first line treatment, class 1B indication in the patient with a unilateral renal artery stenosis. Bilateral renal artery stenosis, of course, you can still use the ACE or ARB, but you have to be cautioned about the hyperkalemia. There is no any absolute contraindication for using that, but however, we prefer the calcium channel blocker and beta blocker compared to ACE ARB in the bilateral renal artery stenosis. Reacceleration. There's clearly 3A recommendation. So we don't have to put the stent reacceleration in each and every patient of renal artery stenosis. Only certain group balloon angioplasty required in the FMD, which has more evidence 2A, not in the atherosclerotic renal artery stenosis. So now coming to second cause, the primary aldosteronism. So this is again the second to the next to the renal artery, renal parenchymal disease and renal artery disease. There is a 6 to 20% prevalence in the total secondary hypertension cause. Patient may have direct symptoms of the fatigue, muscle weakness, polyuria, polydipsia. We do biochemical tests. We find the aldosterone level high, renin level is low. So the main test to differentiate this type of hypertension is to plasma renin aldosterone ratio. So when plasma renin aldosterone ratio is high, we have to suspect this. The patient with the hypokalemia, again, we have to always think for primary aldosteronism. The second thing that ideally we have to stop the medication MRA inhibitors like spironolactone, eplerenone at least 6 weeks. Again, may not be possible in the ideal world, but if you want to really reliable your test, then we have to stop this for at least 6 weeks. So absolute ratio, aldosterone ratio again is key. There are several medications we can start which cannot affect or less affect on the AR ratio is the verapamil, hydralazine or alpha blocker. So many times when patient comes to you, you don't have to wait for the result, then you can start this alternate antihypertensive medicine which does not affect the aldosterone ratio. The CT scan which is showing the Cons tumor, this MRI again showing the Cons tumor. Next cause is pheochromocytoma, again very rare cause, which is chromaffin cells with catecholamines. The symptoms are, history is very important here, intermittent hypertension, palpitations, sweating, anxiety spells, precipitating triggers are always there. And again this patient have the, could be paraganglioma as well. As you can see in this slide, the paraspinal many gangliomas you can see here, which can secrete the these chemicals and which can cause the pheochromocytoma. These are the tests to find out the plasma-free metanophin has the highest sensitivity and specificity compared to 24 hours. So we prefer plasma-free metanophin first time is the first test. If it's negative, then you go for 24 hours VMA. Again, this scan is showing the adrenal pheochromocytoma. The sensitivity of diagnosis of pheochromocytoma is again based on CT or MRI finding or based on scintigraphy, which is again highest specificity but less sensitivity. Treatment is again the alpha blocker is the first choice. Don't give the beta blocker initially because which can cause crisis, and many times we have to go for the ligation of renal artery in this group of patient. Cushing syndrome is another cause, again rare cause, only 0.1 to 0.6% patient with secondary hypertension in this reason, which could be the central or the peripheral. In central you can think for pituitary adenoma, and local you can say adrenal adenoma. Symptoms, history we can see is a weight loss, weight gain, obesity, abdominal stria. These are the picture of the Cushing syndromes, and we have to always suspect when we see this for patient for Cushing syndromes. Diagnosis based on the 24 hours urine cortisol, and we have to confirm with the low dose dexamethasone suppression test, and other tests are the CRS suppression test, which is helpful. When you suspect any tumor or mass, then you always think for CT, MRI or other imaging tests. The treatment again, treat the cause, pituitary tumor resection or the radiation, and many times we have to medical manage with the metirapine or ketoconazole for bilateral adrenal hyperplasia. Coarctation aorta, common in the male then female, again young age difference in the blood pressure in the upper limb and lower limb, and many times if you don't treat, then 70% patient will have left renal failure by the age of 40 years, and 75% will die by the age of 50 years. So this is very important to not to miss in any clinical practice for secondary cause. So these are the collateral circulation happen after coarctation aorta, and there is a rib signs, you can say the notching of the rib, which we always in the book picture, we are not seen practically in till now, but you have to always mention when you discuss coarctation aorta about rib notching in the chest X-ray. Again, this is rare genetic causes, Liddle syndrome, which we don't come across routinely. This is a very good review article which was published in 2020 in this cardiovascular prevention journal, and which is very detailed about the common form of secondary hypertension. This is a summary of that. Renal artery stenosis, we always think for renal bruit, worsening creatinine level after starting ASO-ARB, renal parenchymal disease may be asymptomatic, and you can just see this summary slide, and we already discussed about the different investigations in the previous slides. So now just coming to the last two slides about the take-home message. Which patient should be considered secondary hypertension depends upon the patient age. Younger age, definitely good to find out the reason. Older age with the resistant hypertension, we have to find out the reason. History is very important. Clinical examination, especially endocrinology case, we have to find out the examination. Biochemical and imaging will supplementary to confirm the diagnosis, and the aldosterone renin ratio is very important test to assess the secondary hypertension. And any patient when you suspect increased rise in creatinine or hypokalemia, then we have to always consider for the primary aldosteronism or Cons syndrome. And failure to recognize secondary cause can lead to the major disaster complication of the cardiovascular and renal, and mainly younger patient we have to consider for the FMD, glomerulonephritis and coarctation aorta. In older patient, OSA, aldosteronism and renal aldosterone system. So thank you for this giving opportunity today for this talk. If any question, we can discuss now.